hour more on that. Print that out, write notes on it, or write your notes of whatever you're studying off of there. Upload it. There's a Dropbox called GI Lecture Supplement. Upload that in there, and that shows that you did all 6 hours of your time. Okay, that way you can get all your class reading ready. Huh? Yeah, so we are required for accreditation and all that to give you 6 hours of stuff, okay? So it can be outside projects. So what I did was I made that study guide for you that's based on the content you need. So I'm going to lecture for 3 hours, and then I gave you that study guide that I need you to spend 3 hours on it at least, and write your notes in the blanks, or write it on another piece of paper or whatever. And however you studied that, just upload it back into the Dropbox. If you don't take notes, just print that out and upload that study guide into the Dropbox under your name, okay? And yeah, let whoever that is in.
So we just scan it and upload it, and there's like
Our notes that we
Yeah,
take today.
there's a GI lecture supplement Dropbox. Just upload it in there, and then you'll get your full 6 hours of credit for the class. And I try to break it down. I haven't taught this in a little while, so I went through your textbook and was reading things, and I looked at all the test questions, and I did the last set of EAQs. The first 2 sets were done. I did the last set. So trying to make sure that you can do well on your tests, okay? So,
You're my hero.
thanks for the candy bar. All right. So, like I said, this has so much information, and I had to take this PowerPoint. I took a bunch of stuff out that I didn't think was relevant, and I added a few things, but so bear with me if I'm a little rough because I didn't create this PowerPoint. Well, I'm going to use it, okay? Problems with the GI tract are numerous and represent every type. Let's see, this is going automatic. See, every type of pathology, such as, okay, bleeding, perforation, obstruction, that's all in the slides. Inflammation and cancer. GI tract is 23 to 26 foot long path. You don't need to know that for your test. It's just the FYI. And I never forgot that in my A&P class. I took A&P at JC, and my professor was in the military, and it's kind of told some gruesome stories, but I never forgot them. And he said one of the things they did to the prisoners is they would take their intestines out and nail them to the tree and make them run around the tree. And he said that's how long your intestines is. So it's up to 26 feet long. So that's gruesome. I'm sorry, but you won't forget it. You have a long intestine. Adjectives. Do you have the adjectives? Who's my adjective person? You got them out? Okay. All right. You do not have to memorize all of this. This is just to show you that there are referred pain. So if someone comes in saying that their shoulder hurts, it may not be their shoulder, okay? So you can just see there's various things going on. What else is kind of awkward? Oh, pancreatitis, cholecystitis, and ulcers. That's kind of like an epigastric area. Appendicitis is always right lower quadrant. Oh, you can see this guy's even got some pain in his back from the ulcer. So it can be different than what you think. So shoulder, if it was hurting in the shoulder, of course shoulder would be one of your differential diagnoses, but then it could be liver or something else. This is some of the tests we're going to go over. CBC. So for CBC, when you think of GI, you're probably thinking of the H&H, because with GI you can have a bleed, right? So you can be looking to see what the H&H is. You're probably going to be looking at the white blood cell count, because that could indicate an infection, right? PT, INR. The PT you're going to look at mainly with the liver, because the liver makes all the platelets, right? Y'all remember all that from anatomy and physiology? Some of it. So AST, ALT, when those are elevated, that could indicate like pancreatitis and things. Same thing with the amylase and lipase. And the reason it says 24 to 5 days is because that's how long it can be, like it spikes and then it kind of calms down. Bilirubin, that's liver stuff. Ammonia is liver. The CEA and CA19-9 are tumor cancer markers. Albumin, that's your protein in your blood level. And GI barium study. What I want to point out about the GI barium study is anytime you do this, you're going to have to inject dye, and you always have to ask people if they're allergic to what when you're injecting dye. Iodine shellfish, right. So if you're going to inject dye into someone's body, what kind of patient education would you give them? Not related to allergies, something else. Fluid. Now why? Why do you want fluid? You got to protect the kidneys, right? So if you're going to give someone a GI barium study, what kind of test would you want to do? Okay, yeah, you want to see if their kidneys are in good shape, right? If they can handle this. And then when the test has to be done regardless, there are things that you can do to help protect the kidneys on the front end, but definitely you want to tell them to flush the kidneys out to try to get the dye out as quickly as possible. Good. Y'all already know this stuff. All right. So stool test, you're looking for blood, of course, and I don't know if anybody's ever had to do a fecal blood. You get the little cards, you take them home, you got to put the little smear on them and bring them back. And the thing with that is there's always 3 tests with 3 separate stools, right? So if you have one stool, you can get one test, and then if you have a couple hours later another one, you can get another test. But you don't want to do them all on the same stool, different ones for different stools. And that is in your textbook. I'm not testing you on that. This is the FYI, the raw fruits and vegetables, and I've never even seen that in practice, but it is in your textbook, so I want you to know it's there. And they're looking for ovia parasites in your stool, fecal fats, and infectious agents. So when you send this stool sample, they could be looking for any of those things. And that way, when the doctor says send this for stool, you may want to specify, well, what are we looking for? Because it could be any of those things. And if you don't specify, they won't test. Okay? So if you have stool that is bright red, what does that indicate? Lower because it's fresh. And then so the dark would be the upper, right, because it's old. Good. You do need to know this. You need to know what age-related changes happen with elderly and the GI. So these are things you need to know. They're going to have, what is that fancy A word? What is that? Who can guess what that might be? What does A mean in front of any word? What does A mean? Without. So this person, it doesn't have as much, right, they don't have as much acid in their belly anymore. So if they don't have as much acid in their belly, that affects breaking down food, right? But what else can it happen? Well, they might have bacteria that's not being killed off because the acid's not in there, right? So it's more alkaline environment, right? The liver is less efficient in metabolizing drugs, so that means the drugs that have a half-life could be extended for elderly people, right? So for us, it may clear me in, 4 hours, but for them, it might take 8 hours. So we have to be careful with the dosing of any medication with the elderly because they can't clear it as fast because it goes through the liver, but where else does it go through? The kidneys, and they have decreased kidney function too. They are more common to have diverticuli in the colon. Do y'all know what diverticuli is? It's the pouch. Yeah, it's the pouches. So if you have those pouches, then like seeds and food and things can get stuck in there and it can get inflamed, and then that leads you into diverticulitis, right? So they have more risk for that because they have more pouches. Reduced peristalsis, so then they're going to be increased risk for constipation. And also, you have to drink a lot of fluid, or you could be at risk for dehydration and constipation. And do a lot of elderly people drink a lot of water? No. Probably because they have to get and pee too much. There's just many reasons why they won't drink water. So they're at risk for that.
So basically, this is when we talk about constipation. So, it's this hard stool, difficult passage. If you strain, it can cause hemorrhoids. There's certain medications that cause constipation, and we study what antichlorogenics. We studied that, right? Remember, can't see, can't poop. Yeah, okay. So, antichlorogenics, diuretics, right? That's what they do. They make you pee, right? Diuretics. What kind of food or drink is a diuretic?
Tea.
Tea, coffee, sodas. Yeah. So if you drink a diuretic or take it as a medicine, then it can make you have constipation. What else? What other things can cause constipation as far as medicines? We talked about it. Opioids. Yeah. So old people sometimes are on opioids, right? So that makes them even more at risk. Aluminum-based meds, which are some of your antacids, and that's on your slides. And iron. Did y'all know that iron can cause constipation? That's why a lot of people won't take oral iron, because it makes them constipated. So they have to get an IV, okay? Okay, so if someone's constipated, they're going to be probably taking some kind of laxative. So, do y'all know anything about laxatives? Do what?
Overuse could make it worse.
Yes. Do not overuse them. You need to know that. That's good. Because you can become dependent on laxatives. So, do you take a laxative every day just to keep you regular? No. Good. And do y'all know what impaction is?
Yeah.
Can nurses fix that?
Yeah.
Yes. But what is one thing you have to watch for?
Vegas.
Good. Vagueling, because it'll make your heart rate go down and the person could pass out. But they're usually not standing, or if they pass out, they're not going to hurt themselves. All right, so diverticulosis. Is diverticulosis the same thing as diverticulitis?
No.
What's the difference?
One's a flare up.
One is the pouches, right? And the other one's actually something inflamed or something's in there causing a problem. Obstructions. I think we got pictures of these. Let's keep moving. I think I've got pictures of all these. And hemorrhoids. Hemorrhoids can be internal or external, right? Yeah, they can be. So you could have a little bit of bright red bleeding but not know you have a hemorrhoid. And then if they go in and do the scope and they see it's just a hemorrhoid because you can't see them all the time. Go back. We said that. Okay. What you do need to know about this is that if you have this, you're not wanting the person to have a lot of increased pressure in their bowel, because increased pressure can cause problems. So, but if you think with me, increased pressure, so you probably don't want this person taking laxatives, because the laxative can increase the pressure on the bowel as it tries to make you evacuate. You probably want to think about picking up something heavy. You probably want to make sure you use your leg and your back body mechanics, because if you're straining, you may put pressure down there. I know it's a far stretch, but I'm telling you for a reason, okay? So we don't want this person to have any increased pressure in their gut. And also there's some medicines that different, like constipation medicines work different ways. Some of them are stimulants. You want to make sure they're careful taking those too, that they make sure they ask their doctor before they take any kind of medicine that would stimulate a bowel movement. And they don't let pregnant ladies take those either, because it will induce pregnancy, right? So they can take like Colace, but they can't take like some of the other ones. Who knows the old wise tale of what you drink to have a baby?
Castor.
It's a stimulant. Who's done that? Hey, I did it. It works.
It didn't work for me.
It tears your stomach up.
For like 5 years.
Oh, no. It is pretty nasty. But anyways, it's a stimulant, so you wouldn't want the person with diabetes to be taking that, okay? All right, so you can have a mechanical obstruction or functional. Mechanical, I have pictures on the next slide. Let's see. Okay. And anybody that's had kids probably learned about this, and you'll learn about this in your mother baby too. The interception at the top, you don't have to know the names of them, but basically it telescopes inside of itself. That's a mechanical obstruction. It can twist, and then that causes system obstruction. So these are mechanical obstructions. Now the functional obstructions would be things like you went to surgery, and then when you're out of surgery, you haven't had a bowel movement yet because your bowel is all still asleep. There's no real obstruction, it's just a functional obstruction because everything's still sleeping. And we don't go into what you do. Of course, there's surgeries and things like that, but I think I'll talk about that in the next level. Hiatal hernia. Y'all heard of this? Somebody who has this, what kind of problems do they have? What? Yes, acid reflux. Why do you think that this, looking at the picture from what you know, why do you think that person would have acid reflux? Well, part of their stomach that has an acid in it is outside the sphincter, right? Okay. So who do you think is a high risk for this? Usually obese, people who eat large meals and then go lay down, things like that. And they can correct that with surgery too. Oh, look, we're back at hemorrhoids. Okay. So, like I said, it's going to be a surprise for me too. Internal, above the internal sphincter, external outside, and of course, straining, childbirth, sharing, any of that can cause hemorrhoids. So if someone is prone to get hemorrhoids, you might want them on a stool softener so they're not straining so much. They're itching, pain, bright red bleeding, and or blood streaks on toilet paper or your stool. All right, so let's think about this. It sounds so simple, so you're probably like, I know that, okay? But if you have a test question on hemorrhoids, are you going to get it right because you just said, oh, I know that? So let's think about it for a minute. Your patient is sitting up in the hospital, and they call you in there, and they want you to come look at their stool because it has red on it. Oh my God, I'm bleeding. So, and you look and you said, oh, do you usually have hemorrhoids? And they say yes. And then what if it's a hemorrhoid? So if it's a hemorrhoid, would you expect to probably see this? Okay.
So ask them if they have a hemorrhoid.
Ask them, have you had hemorrhoids? Or the doctor may say, oh, it's a hemorrhoid. The doctor will know. Or if they're not sure, then they can do a scope, and then the scope can definitely see what's going on. But if you know you have a hemorrhoid, and then you have blood on your tissue, it's your hemorrhoid, okay? Don't freak out. Because, blood and stool can be one of the signs and symptoms of colon cancer. All right, so that's why you need to know the history of your patient.
Is it bright red?
It will be because the hemorrhoids are usually like lower down.
But in cancer, is it bright red?
Yeah, it can be. But it'll probably be more than just the streaks. It'll probably be more blood. But that's why you're not going to know all the answers by just how your patient presents. Because we're going to talk about ulcerative colitis and Crohn's, and we're going to talk about other things that can maybe have bleeding in the stool. So even the doctor would not know what it is, but do you have an idea? It's either hemorrhoid, it's either cancer, it's either ulcerative colitis, then you know these are what I'm trying to rule out. And then they start some of the tests to rule those things out. So you won't know. You won't know just by seeing the person have blood in the stool. You won't know. But what you do need to know is you need to make sure you get a good history on the person so you can kind of get a better picture of what's going on, right? So what is a common GI problem that older clients experience more frequently as they age? Good. So where we're going now is that there's all these things that, all these are going to be on your test, okay? All these. And some of them are infectious and some of them are inflammatory. So as you're studying in your mind, have them in those categories. Is it an inflammatory problem or is it an infectious problem? Or is it, and then both, is it both? So kind of break it out that way as you study. So gastritis, this is that traveler's diarrhea. You always want to ask if they've traveled out of the country. They've probably eaten something that was like contaminated, and now they've got increase in frequency of water, stools, inflammation. So here's the interventions. You want to replace fluid. So if someone has diarrhea, they're at risk for dehydration, so you're going to give fluid. Electrolytes. You can give drugs to stop it. Sometimes they want to make sure that do the stool test first, because if it is an infection, they may not want to stop it up in there. You know, they may want it to run out. So they'll do a stool test. Antibiotics, skincare, of course skincare. Especially if this person, for some reason, is like bedbound and they can't make it to the bathroom. Have you ever seen, like, or even on babies, if they have like urine or stool on their skin, it just destroys their skin. So skincare is really important here. Did y'all pick out the tidbits? Can y'all tell what's important? Okay, like which what jumped out? Dehydration. How do you fix that? Okay, what else jumps out?
Skin breakdown.
Okay. What about the history? What jumps out?
Travel.
Okay, good.
They drank the water.
I think you should know everything you need to know about that topic. All right, so peptic ulcer disease. All right, so do y'all remember how to do a abdomen assessment? Do y'all remember the order? What's the last thing you do?
Palpate.
Okay, so especially someone who has abdominal pain, you want to make sure you do that last,
Like to eat.
right? If you suspect that they have peptic ulcer disease, does it say, okay, it says that it's a gnawing pain or burning in the mid-epigastrum. So you suspect they have this, that means the pain is here, right? So where is the last place you would palpate? That spot. Because if you're thinking it's appendicitis, you're not going to go right here and start pushing, right? Because that's where the pain is. So you always, even though you palpate last, you also palpate where you think it is last too, okay? What the problem is. So it's an erosion of the mucous membrane forms and an evacuation in the stomach. Okay, so it's eating a hole, okay? It can be caused by H. pylori, which is a bacteria. How do you test for that? It's a breath test, okay? They can do a little breathing test and test for that to see if you have that bacteria in your stomach. There's dietary factors, NSAIDs, alcohol, smoking, genetics. So when you think peptic ulcer, just think about all the things that would cause an ulcer, all the foods, all the drinks that would cause ulcers. What do you think those are? Things that are acidic, yes. Alcohol, right? Smoking. Y'all, if smoking is usually a risk factor with everything. okay? I don't think there's anything out there that smoking is not a risk factor.
Could that also be caused too by like taking medications on an empty stomach?
Yes, and that's why it's got NSAIDs on there, because NSAIDs are notorious for, like, putting holes in there. That's why now they have, so ibuprofen, and so now they have Durexis. You ever heard of that? It basically has Pepsid inside the one pill, so it kind of protects your stomach. Why do you take NSAID? So medications, and we'll talk about all the medications, lifestyle changes, and occasional surgery.
I have a question.
Yes.
If you have gastritis on something that you ate, that could also cause the H. chloride with that. Right?
Well, if usually the gastritis is a different bacteria, it's usually Shigella, and then H. chloride is more like the ulcer forming bacteria. So there are two different bacteria that would cause those things.
Do we need to know what bacteria causes what?
You probably need to know a little bit about H. chloride. Which is why I didn't mention the other one until she asked me the question. Okay. All right, so GERD. Most common disorder of the upper GI in the United States. So the LES, you need to know this, okay? There's a picture here. Let's go this one. Okay. So the LES is the lower esophageal sphincter. That's, remember where that hiatal hernia came up? That's where it came up at. That's the sphincter. So whenever it works correctly, it holds those acids down inside your stomach. When the acids get into your esophagus, that's when you get that GERD and all that burning and everything. So we said that a risk factor for that and for this is going to be obesity. Because why? Because the stomach is so big, it's pushing up, and then it can push some of that acid up, right? That's why pregnant ladies sometimes get it. And also, if you eat a large meal and then go lay down, because that food is in there, and then you're laying down, and then the acid can travel up. So you would probably want to teach someone not to do those things, to maybe eat smaller, more frequent meals, to sit up a little while. If there's something wrong with that sphincter, then of course, if it doesn't close, then you're going to have those problems. And there are certain types of foods that can help. It's what they call, it puts pressure, high pressure foods that put pressure on the sphincter to help keep them closed. And I think it's in your slides later, but that's where it is. So let me go back to that previous slide, make sure we didn't miss anything. So the LES is the most common reason for GERD. Risk factors: middle age, older adults, overweight, hiatal hernia, eating large meals before lying down, alcohol, smoking, again surprisingly, and tube placement. Okay, that makes sense. What are they talking about tube placement? An NG tube. If you have an NG tube, where's the tip of it? In your stomach. So what can't close? Right, because there's a tube holding it open. Okay? Healing process can produce Barrett's, esophagus, and esophageal stricture. This kind of ties into what we're about to go in, so I'm going to go ahead and say it here. Barrett's esophagus. So does anybody know what that is? It's basically a precancerous condition. So also in your objectives is esophageal cancer. So this is a good plug. So you say, remember in oncology I told you that it happens because your body is assaulted over and over and over, and then the cells begin to mutate and change. So imagine that acid in that esophagus burning and burning and burning and burning. What are those cells going to do? They're going to change, right? So when they change, it's what they call Barrett's esophagus. And sometimes you'll see your patients chart Barrett's esophagus. It does not mean they have cancer. It just means that something in their esophagus has has caused those cells to mutate, all right? So with that, leaning into Barrett's esophagus is a risk factor for esophageal cancer. Does that make sense? Esophageal stricture would be where, what's a stricture?
Close.
Yeah, a closing. So if you have a lot of burning, it could cause that esophagus to kind of close up and then be a stricture. And then what kind of problems do you think that person would have? Yeah, swallowing. Yeah. So this is all from GERD. Seems pretty simple. How many people think have GERD? It's the most common upper GI problem in the United States. But do you see why it's important to make sure you take care of it? Just by things you can do, remember? Don't lay down after eating a heavy meal. Yeah.
Yeah, instead of, I used to have it, but I haven't had it in a long time. And
Have you lost a lot of weight?
me,
Yeah.
I'm bigger now than I ever been.
Well, why did it go away? What did you do?
I didn't do anything, but at that time, I used to, get a little baking soda. Mix it with some water.
Well, why would that work?
Because
Neutralizes acid.
So we can bypass.
Because it's alkaline,
Yeah.
and the acid, it neutralizes the acid.
Yeah.
Good.
Yeah, instead of taking the other people.
PPI,
Yeah.
proton pump inhibitors.
Yeah.
Yeah, the only danger, it would help here, it would help that. The only danger in that is, remember when we said that the person who has decreased acid can have more bacteria growth because there's no acid to destroy the bacteria. So there's risk factors with everything, but all of that will help your GERD. Good, that's a good question. Yeah, and plus, sometimes once you get it healed and get it under control, a lot of times you can kind of go back to some of your normal ways with no problems. Like if you have an ulcer, you gotta wait till that thing's completely healed, and then you can kind of go back to some normal ways without overdoing it. My husband ate a tomato with Tabasco sauce on it and hurt for like 3 months. Because he wouldn't stop drinking soda. So, he never let it heal. All right, here's your diet, just in case. Just look it over, make sure you know. Things that would cause it: coffee, wine, fat food, soft drinks, chocolate, garlic, onion, tomatoes, citrus, peppermint, spices, dairy.
Brown rice.
Thank goodness for PPI.
Does it sound?
Hey, y'all, this is gonna be confusing. Dairy. The reason dairy is on there is because of the high fat. So if you have low fat milk, it does not count. Okay? So don't get confused.
Fat cheese.
I guess. But I think the point of that is the high fat. Because I know if you drink low fat milk, it's supposed to be good for GERD, not bad. So don't get tricked. So, good things: ginger, leafy greens, brown rice, coconut, celery, berries, melon, bananas. I don't eat fennel. Some eat fennel. Who eats that? You do? Avocado, apples, and pears. So that's because apples and pears are fruits, but they're not high in acid. Okay, so just don't say all fruits. Okay, all dairy. All right.
So if you drank really weak coffee, would it be better?
I don't think so, but if you're not actively having a problem, you should be fine. Just if you're having a problem, stop until your problem goes away.
You just can't stop coffee.
I can't either. I carry it everywhere I go.
Most people that have GERD AKB take PPIs, and then they can do all that.
Yeah, but remember PPIs have, I know so much bad about PPIs, but almost everybody knows them.
I can't have tomatoes, I can't have chocolate, I can't have 30 ounces every morning. But I do.
Yes, ma'am. The caffeine affects the GERD. So the caffeine. So maybe decaf. I'm not going to put it on the test. I'm not going to make that test too confusing. Okay. So what classifications of medications will help to relieve the symptoms of GERD that result from reflux? Why is this here? We didn't even talk about medicines. Well, I guess some of the stuff we know it's not.
Bless you.
And we're going to talk about medicines in a minute, but that's in there. Bless you. Okay, here's one. A nurse is caring for a patient diagnosed with GERD. The patient is overweight, has been experiencing dyspepsia,
Dyspepsia.
bloating after meals, aphasia, and chest pain. Why is the patient experiencing chest pain?
Overweight.
Regional.
Overweight.
Overweight, acid. What else?
It's probably referred mainly from the speech.
Okay. Well, let me tell you this. When you go in the hospital, you start practicing, and you have someone come in with chest pain, and they're going to put them through the whole cardiac workup to find out they have acid reflux. Happens all the time. People think they're having a heart attack because it hurts. So that's why when they come in the hospital and they complain of chest pains, one of the first things they do, hey, listen y'all, one of the first things they do is they just start loading all of those PPIs and all that on top of you to see if that helps, okay, before they do all the other stuff. Or sometimes they'll just put you through the whole workup anyway, rule it out.
Can you see that reverse, like somebody thinking that they have acid reflux problem?
Yeah. Yes. Y'all listen up. Listen up. Unless you have something to enhance the conversation, that would be good. But so it can be reversed. If you think you're having acid reflux, you could be having a heart attack, right? They can mimic. Especially women. Women present really weird with heart attacks. They usually think it's acid reflux and it's not. So those are two things to rule out if someone has chest pains, right? Patient education should be Friday. They're just saying, all the stuff we just talked about, eating and things to do if you have GERD. Here it is. Small, frequent meals. Chew food. Now, guys, you are going to be hammered with diet, okay? Throughout your levels, you're going to have gobs of questions about diet. It would be so easy for me and for you to say, I'm not going to look at the diet stuff because I can figure it out. But I'm promising you on this test you're about to take, there